Okay, we will get going. Thank you everybody for attending our AOC PM&R. This is our third installment of our subspecialty series with Dr. Kendall, who will be going over interventional spine with us. And just for some housekeeping before we begin, I will prioritize the questions that came in through the Google survey for all those that you filled out. Dr. Kendall will address some of those directly in her presentation, and the ones that she doesn't, I'll ask afterwards. And then once we get through that, please, if you have any questions during her presentation, please either put them in the chat or you can directly message me them, and I'll try and get to as many of those as we can afterwards. And once we're through all of them, we'll open the floor up for you guys to unmute yourselves and ask your questions directly to Dr. Kendall. So with that, I'll turn the time to Dr. Kendall.
Great. Thank you so much. Thank you so much, everyone, for being here. I'm really excited to talk to you tonight. Let me just see if I can share my screen here. Can you all see that, Tremaine? Are we good? Okay, perfect. So, well, thank you again for being here. I'm really excited. I'm the current president-elect for AOC PM&R, and I'm really excited that we're doing this subspecialty series, and I was really honored to be asked to speak. I absolutely love spine, and I was very fortunate to do an interventional spine fellowship, so I can't wait to tell you all about what it's like being in this subspecialty of medicine here. Here we go. So I I usually don't like to kind of go about or talk about like my background, and then I usually don't share a lot of personal information about myself, and then I always get told afterwards, oh, we didn't really get a sense for who you were. So it's still kind of awkward for me to talk about some of these background things, but I think for this, I think this is pretty relevant, and I think just kind of helpful, I think, to see how or what my path was to get to this point. So I'm a DMU graduate. I graduated back in 2007. I actually was in the original 2006 class, but then I decided to do the osteopathic manipulative medicine fellowship. So it pushed me back a year. So I graduated in 2007. I really, things were different at the time that I graduated. So at that time, if you wanted to become AOA board certified, which I really did, that was really important to me as a DO to be AOA board certified. At that time, they were requiring that you do a traditional osteopathic rotating internship. So I really liked that type of internship just because it was very broad. It had a really solid foundation for medicine that I thought that you needed for physical medicine and rehabilitation. I liked that you had the osteopathic background and training in that as well. And I liked that it gave you a little more elective time than some of these other medicine prelim years and things like that. So that worked out really well for me. I was in Michigan for that because I did things backwards. So I matched for my residency first, and then I scrambled into an osteopathic rotating internship. So I matched for residency at the University of Michigan. My husband had, and this was back in the day too, we used to have the osteopathic match and then the allopathic match. And so my husband is also a DO. He went through the osteopathic match. And at that time we knew that he matched, and I had a 10-day window to change my rank list so that I could try and match with him. So he matched first at Michigan State. I ranked University of Michigan #1 then, so that we could try to be together for residency. And we were really fortunate that it worked out for us. And then I ended up staying on for a spine fellowship at the University of Michigan. I graduated in 2012. That fellowship at the University of Michigan for spine is non-accredited. And we'll talk a little bit more about what that means a little bit later on in the presentation. Just a little bit of background. I know we've got a lot of students on that signed up for this. I see there's also residents. I was really surprised. We actually have quite a few attendings who signed up for this. This presentation is geared more for students and a little bit more for residents as well. So I apologize to the attendings. We'll go over some of this basic stuff that maybe feels a little less relevant to you as an attending. But for our students, why did I choose PM&R? PM&R really just felt very natural to me as a DO. As an osteopathic physician, we're trained to look at the whole person, to practice holistically. And that's essentially what physical medicine and rehabilitation physicians do too. The osteopathic tenets that we look at with the self-healing, self-regulation, health maintenance, all of that lends itself very well to physical medicine and rehabilitation. That's essentially what we're doing in this field. And then, of course, we know that structure and function are interrelated. And again, that's a lot of what we do in PM&R. We're looking at function, we're looking at what structural things are happening with a person that is affecting their function and what we can do to optimize that function. So I just really felt like as a DO, PM&R was just the perfect fit to blend that osteopathic practice with what I wanted to do with medicine. I also liked PM&R a lot. I loved working with people of all different ages. I kind of have a special place in my heart for geriatric populations, but I still liked working with people of all ages, and PM&R really allows you to do that. I like that you really work with lots of different specialties. We work very closely in my field, especially like orthopedic surgery, neurology, rheumatology, and primary care. If you do inpatient, you're working with a lot more specialties beyond that as well. But I really liked that kind of working together as a team. And then, of course, you're leading a team of other providers to take care of this patient. So, especially on the inpatient side, you're leading physical therapists, occupational therapists, behavioral health therapists, nurses, social workers, discharge planners. There's a lot of people that come together to take care of these patients and make sure that they can go home and function as safely as possible. So I really, really love the team approach. I really liked PM&R too, because you're looking at functional goals for most of the time. There's some medicine, and the medicine is very important, but the main thing is the function. And patients really can kind of set their own goals for function, and thus are typically a little more self-motivated. I got a little tripped up in primary care. There's so many standards, like, oh, if you have type 2 diabetes, your blood pressure has to be, less than 140 over 80. And a lot of patients, they don't care. They don't care what the hemoglobin A1C is. And so it felt like you were constantly fighting patients. With PM&R and having patients set kind of their own goals, it's easier to work together towards those goals. And I really liked that. And just in general, the culture of PM&R, the people who go into PM&R are typically very friendly, very helpful, very supportive. It's a really just kind of nice group of people that go into it. One of my friends, she told me, she's like, well, we're working with people who have disabilities, and people who work with people who have disabilities tend to be pretty nice. So it really just seemed like a perfect fit for me. And again, very similar to the osteopathic culture that we have. So why did I choose spine? I love OMM. I did the OMM fellowship, and I wanted to make sure that whatever field that I went into, that I could do OMM. And spine is one of the really great subspecialties to be able to use OMM. I use OMM every day in my practice. My patients love it. That was one of the big reasons I think why I chose spine, was because I wanted to use my OMM. I also really liked that, there's pretty much 6 treatments for spine, and you get to know all of those really well. So, you can always tell the patient that you're just going to watch it. A lot of these kind of acute, simple back pain cases are going to get better on their own, no matter what people do. I love physical therapy, working with a physical therapist. There's all sorts of different types of physical therapy. I really like that we're trained to know how to come up with a diagnosis and then tell the physical therapist exactly what we want them to do with the patient, rather than just saying evaluate and treat. I think that's really what makes us stand out as physiatrists, is being able to write those physical therapy scripts. Obviously, there's the alternative treatments. I hate to put OMM or OMT in there, but that's kind of where, in general, the House of Medicine kind of classifies it. Chiropractic manipulation, certainly chiropractic manipulation has its place. And you have a lot of patients that see chiropractors and have done very well with chiropractors. So I think that's something that, you just kind of work with your patient if they're already receiving that type of manipulation. Functional medicine is something that I'm really interested in. That's a big movement. I think we're going to hear a lot more about that coming up, and that goes along with nutrition. Medications, there's kind of a finite number of medications that we use. I liked that we didn't have like a super long list, and there's not a lot of major changes in the medications that we use. Injections, I like doing injections. Obviously, we'll talk more about that. And then there's the option to refer to surgery for certain patients. And I think learning spine, you kind of learn who's going to be a good candidate for surgery and who's not. So I like the idea of knowing one area really well. And again, I liked mainly seeing older patients, but again, with spine, like I see kids. I think the youngest kid that I've seen was 9, and we see, I see people all the way up into their 90s. So I think too, I was really fortunate at the University of Michigan, they introduced you to spine pretty early. So I had a spine rotation in my PGY2 year. And so we were already in the fluoro suite doing injections as a PGY2. And I think when faculty kind of tell you early on that they see like a natural talent in you, I think that kind of makes you naturally gravitate towards that too. So that's kind of what brought me in. But certainly you can do spine and not do the procedures if you don't want to. If you kind of find that you're not a procedural person, you can definitely still do spine. And you will have a lot of groups that want to hire you, because most people who do spine do the interventions. And so they're always looking for more people to do the clinic side. So what do I do currently? I'm currently the program lead for medical spine for mHealth Fairview, which is one of the large health organizations in Minnesota. I spend 4 hours a week, so about an average of an hour a day, doing administrative things. So that's coordinating operations, looking at clinical quality, directing quality initiatives throughout the system for spine, kind of making sure that we're all practicing the same. And then I am mainly a clinical physician, so meaning that I'm seeing patients and doing procedures. So that is about 28 hours per week. So I work 0.8 means that you're working 4 days per week. That's 80%. So I'm very fortunate and just working 0.8 right now. So as I've kind of alluded, I love being a DO. I've been very involved in the osteopathic profession. And I don't list this to kind of brag. I list this to like encourage people to serve. I really think that the osteopathic culture and community is about giving back. And I look at what I've received from those who came before me, and I look at what I can do for those who come after me. We need more DOs to continue to be involved. We see people who, do great as students, and then they kind of, we see less of them during residency, which is to be understood. And then we hope that they'll, be involved when they're in attending. And I know people get busy. I'm very busy too, but it's very important, to remember that people will always need you, just as you needed people when you were coming up. So I just encourage you to try to be involved and to try and help others out who are coming up behind you. So outside of work, so PowerPoint chose the pictures, and apparently it's very puppy friendly, because my puppy ended up being the biggest picture out of the 4. But that's my dog Riley. He's a little clique eye puppy. He's 3, and he's not a puppy. He's 3 years old. That's as big as he's going to get. He's 17 pounds. But outside of work, I really love to Irish dance. I power lifted up until the pandemic, when the pandemic kind of shut down all of the powerlifting meets. And of course, like the loves of my life here are down at the bottom. My daughter, Sophie, she's 10. And then my husband, Dan, like I said, he's an emergency room physician. We actually met in med school at DMU. So about my day. So what's the typical schedule for me? I like to get up early, and then I like to get my workout in right away. I just kind of wanted to throw that in there. It's really important to exercise. I think that is one thing that is really important for health. And it's one of the first things I think that people kind of throw to the wayside. So I would say that there is a few years before when I was attending that I didn't work out, and I was taking a nap like for 2 hours on Saturday and Sunday every weekend. I was so tired. And then once I started working out on a regular basis, like I don't take any naps anymore. I would say I can't afford to not work out anymore because it gives you so much more energy. You're so much more efficient and effective. So just wanted to put a little plug in for working out. So my clinic day starts at 8 a.m., but I like to get to work earlier. So I usually arrive at about 7:15 because I like to prep for the day. So usually you're reviewing the charts of the patients that are coming in. Epic actually allows you to start pre-charting on those patients. If they have labs or imaging that you can review beforehand, you can already be documenting that into your note before they come, just to save yourself some time. Usually there's messages that have come in overnight, so you're clearing those out. And then I see patients for 4 hours in the morning. So, and again, I have that half day split. So if I'm doing injections in the morning, then in the afternoon, I'll switch and I'll do clinic in the afternoon. So most places will usually give you at least an hour break where you're not seeing patients. I can't say that I always get to eat lunch during that hour. I usually try to cram something down, but usually you're catching up on charting. People need to talk to you. You've got emails, you've got more patient things that are coming in. So usually like you end up running a little bit behind. So even though you stop seeing patients at 4, by the time you're done, actually coming out of that last patient's room at maybe 4:15, sometimes 4:30, and then you're cleaning up just the rest of your charts, anything, any other emails, messages, things like that. And then in the evening, I try to keep it so that when I leave work that when I'm leaving work, it's done. I'm not going to log in at home. I try to take care of everything before I leave. And then I know that I can just pick it up when I get in a little bit early in the morning. So it's a pretty nice schedule. I would say there are some clinics that probably go a little bit longer, starting at 7 or going till 5. But pretty much for spine, you're looking at an 8 or a 9-hour day. Oops, sorry. So in clinic, what we do, we're seeing a lot of new patients. So you take your history and your physical exam, you're reviewing any imaging that they've already had done before you come in, and then explaining what that means. The biggest thing is that between the history, the physical exam, and if you have any imaging, you want to try and come up with what the pain generator is or what their diagnosis is. And then if you don't have imaging, or if you can't really tell what's going on based on the history and physical exam, then you're going over with the patient what further workup that they need to have done, whether that's imaging, if they need to have an EMG, if you feel like there is something else going on, if you're worried about, an infection or, unfortunately cancer, there may be some laboratory tests that you need to do, or sometimes you need to order some vascular studies or other medical studies. And then you take time to discuss the treatment options with the patient. So pretty straightforward. Our typical patients, the age range again varies. You can see young kids to, very old people. I would say the average age that I tend to see is about 65 years old. Majority of patients are older than 55, but as I was saying this, as I was preparing my presentation, I was like, oh, most of my cases are people under 50, and then today, like everybody was under 50. So again, you never know what you're going to see. You can see that pretty wide age range. You see lots of different types of people too, people who are pretty sedentary, people who are really active, people who are athletes, sometimes high-level athletes. You see a lot of work comp. There's unfortunately a lot of people who injure their backs at work. So work comp, and then a lot of auto injuries. There are, I think, 11 states. I used to be able to list them, but I can't remember all of them anymore. I know Michigan and Minnesota for sure are no-fault states. So meaning that your auto insurance will cover up to, in Minnesota, it's up to $20,000 of medical expenses for any injury sustained in an auto accident. So again, a lot of people have neck pain or back pain after a car accident, and they're coming in to see people, and those that just means it has to be documented a little bit differently when you're seeing those auto injuries. And then we see a decent amount of pregnant patients too who are coming in with back pain. So I just threw a couple of cases in here. Again, these are mainly for the students. But so I recently saw a 40-year-old man, and his past medical history is just significant for leukemia, but it's been in remission for quite some time. And he was coming in with, I thought this was an easy slam dunk case, you know, right-sided low back pain, radiation of pain going down the leg. So pretty classic for sciatica. He told me it concentrated a lot in the right buttock. Didn't have numbness and tingling or weakness that he noticed, just a lot of leg pain. He had normal strength, reflexes, and sensation, positive straight leg raising test, you know, pain with hip internal and external rotation. He had a positive Faber's test. The kicker was, though, is that he was coming in for a second opinion. So that kind of raised some things. I was like, well, maybe this isn't going to be a slam dunk case. But his MRI showed that he had a right L5-S1 disc herniation, which was causing lateral recess stenosis and impingement of the right S1 nerve. So I was like, oh, well, we'll just do an epidural injection at L5-S1. If he's had one there, we'll do one at S1, S2. We'll send him to some physical therapy, but he had already done that and it hadn't worked. So now he's coming to me saying, what else can we do? So I decided to order a trial. We ordered some gabapentin. And then one of the other things that I've kind of learned in my experience is that when that pain concentrates in the buttock, it can be coming from quite a few different things. But what I've kind of learned is that the hip tends to be a fairly big culprit. So we had an MRI of the hip and it showed a labral tear. So I thought, okay, you know, maybe it's this labral tear that's causing it. So we did a diagnostic hip injection for him, but unfortunately it didn't provide relief. So he's pretty frustrated at this point because, you know, we've done a couple of things now, showed a labral tear, but then he didn't get relief with the diagnostic injection. So I brought him back in to re-examine him. So in this time, like I did a full osteopathic structural exam. I don't always do that on every new patient. A lot of times you just don't have time. But so he had significant osteopathic somatic dysfunction of the lumbar spine, sacrum, and pelvis. So I treated him with OMM and he had immediate relief, but unfortunately it didn't last very long after I saw him that day. But we did come up with, we think, okay, this is sacroiliac joint pain. That sacroiliac joint, we were kind of classically taught that like that SI joint can refer pain down the thigh, but it typically doesn't go below the knee. But once you get out into practice, you see that SI does refer past the knee quite frequently. I was talking to another attending about it and he was like, oh yeah, he's like, there's so many ligamentous attachments near that SI joint, and those ligaments can refer pain down the leg like that. That's pretty common. And I have seen that where, you know, especially if there's no numbness, tingling, or not necessarily any weakness, like if, and if there's no disc herniation on the MRI, his was a little hard because he did have a disc herniation that correlated with the side of his pain. But that SI joint can be the culprit of that distal lower leg pain. So we sent him back to physical therapy with this new diagnosis. The physical therapist immediately messaged me and said, I think we're on to something. Like, I'm really excited to work with him on this. And then we were going to do an SI joint injection to confirm it. And unfortunately, insurance denied it. And that's another thing that you have to deal with a lot in this field, is that we get a lot of denials for mainly injections. So we're appealing that with the insurance company, but that's something that kind of goes hand in hand with this field, is that you'll do a lot of arguing with the insurance companies. It's usually not a big deal once you get on the phone with somebody. I don't want to jinx myself, but knock on wood, I've won every appeal that I've had to do. Some of it is just jumping through a hoop. They just want to see if you're willing to get on the phone and talk to somebody. But definitely these insurance appeals are becoming more and more. So if the SI joint is confirmed as the etiology, we'll continue with that physical therapy. That hip labral tear may be playing a role in the biomechanics of the pelvis there. So that's something that we will keep in mind. And then he may benefit actually from pelvic floor therapy. I've had some patients who have had some really tough SI joint pain, where if you get a good pelvic floor therapist or postural restoration therapist, and especially in combination with that OMM, you can really help patients out a lot. The last thing you want to do, there are some surgeons out there that really love to fuse the SI joint. Kind of torn on that. I've seen it work well a couple of times, and I've seen it not work so well several times. So especially in a young person like this, if you can avoid if you can treat their pain so that they don't keep seeking care with somebody else, because if they keep seeking care, they'll find a surgeon who will fuse that for them. So second case that I want to do, and I have a couple more, but I think after this one, we'll probably keep moving through, and then we'll, if we have time or if people want to, we can come back to it afterwards. But this one was one that really stood out to me because I was a fairly new attending, probably like 2 years in. And I had seen this woman, and she wanted her husband to see me. So he was a 75-year-old man, coronary artery disease, peripheral arterial disease, and he was presenting with chronic bilateral low back pain with pain going into the legs, thought to be radicular, slightly worse on the left side compared to the right. Seemed pretty classic for, lumbar radiculitis or maybe stenosis, especially given his age. So his primary care physician had ordered an MRI. And of course, like it showed multi-level foraminal stenosis and central canal stenosis kind of throughout the whole lumbar spine, but worse at the L4-5 level. He was referred actually to a spine surgeon, which this kind of scenario happens a lot. So referred to a spine surgeon because the primary care physician ordered the MRI and then sees the word stenosis and thinks, okay, we got to send them to a surgeon. So a lot of these surgeons now are screening their referrals, and this spine surgeon said, no, I'm not going to see this patient because he hasn't had conservative treatment. So send them to medical spine. So I saw him, took his history, we talked. On my physical exam, he had normal strength. He had absent reflexes, which isn't uncommon for somebody his age. He had normal sensation. He had some mild swelling of the lower extremities, and then his feet were like really cool, like cooler than what I would expect. So then, sorry, I don't know what just happened there. So he didn't have pulses on his exam, and pulses is something that I was checking at the time more because for insurance requirements back at that time, you had to examine 8 systems. And I was always like, we learned about sometimes how, you can have vascular problem that people think is actually like a back and a referred leg problem that's really a vascular problem. So I was like, yeah, I'll include vascular in my 8 systems that we do for physical exam. But it actually now after this case is something that I check on every single one of my new patients. So he didn't have any pulses, which I thought again was a little concerning. Especially with his feet being so cool. So I asked him about his surgical history again, because he hadn't really told me, that he had any major surgeries. I think he'd had like an appendix out or something and cataract surgeries. But then I was like, well, did you have any, you have peripheral arterial disease? Like, have you had any like problems with your arteries? Did they do any sort of procedure to kind of open the arteries up anywhere? And he's like, oh yeah, he's like, they did this procedure. He's like, I didn't think it was a surgery, it was more a procedure where they went in and they put something in my arteries, like here in my groin to keep them open. And I was like, okay, so we know we have a history of vascular disease. We know that you've already had like some grafting done. So I sent him for a CT angiogram of the lower extremities, specifically to look at the femoral arteries. And he had severe, actually it should be say arterial occlusion. So he went for fairly urgent surgery, and his wife came back to me afterwards, and he said, the surgeon was in there way longer than he expected because it was such a complex surgery. The left side was really occluded. The right side was bad as well. And so I always remember this because, if he would have gone to a spine surgeon, he probably would have gotten spine surgery, which wouldn't have been the right thing to do for him. So he needed vascular surgery. So I always remember this. And this is why I like being in PM&R. The buck kind of stops with us. And it's really important that, you remember everything that you've learned in medicine to make sure that people get the correct care. So this is kind of a spine case, but just kind of a nice reminder of what you need to be aware of when you're caring for these patients. So then when you're not seeing new patients, you're seeing your follow-up patients. A lot of times you're reviewing imaging, going over any tests that you ordered at their initial evaluation, any treatments that you ordered, you're asking them how things are going, either with physical therapy or if they're following up from an injection, how did they do? I do a lot of trigger point injections. We do a lot of large joint bursa injections, like especially greater trochanteric bursa injections. I do some large joint injections. I used to do those blind for the most part, other than hips. But now I have two partners who do ultrasound guided injections. I never have taken the time to get trained in ultrasound guided injections, but so I send those to my partners now. And then I do a decent amount of Botox injections, both for migraine headaches, and probably the majority though we're doing for cervical dystonia. That's something that I don't see too often, but it's it feels pretty gratifying when you catch that and then you do Botox injections and people feel a lot better. And then I would say about 25% of my, close to, maybe not 25%, like close to 20% of my practice though is OMM. So I do a lot of OMM visits that are sprinkled in with my clinic. So we'll skip the other cases for now. So the procedures that I do under fluoro. So in fellowship, in spine fellowships, especially when they're non-accredited, there may be some nuances in what you learn at your fellowships you wanna ask, but pretty much in general, you should be guaranteed to learn lumbar transforaminals. My fellowship was one of the few that trained cervical transforaminals, but a lot of the spine fellowships will train that. There's not a lot of pain fellowships that are training the cervical transforaminals anymore. You should learn both lumbar and cervical interlaminar epidurals. You should learn the lumbar and cervical facet joint injections and the medial branch blocks. And then of course, learning how to do the radiofrequency ablation procedures. Thoracic procedures aren't performed very frequently. You should ask in your spine fellowship if they train you for those. Mine did, but the thing was, in that year, we didn't see any patients who needed thoracic procedures. So I really didn't get any training in thoracics, but it really doesn't matter because there's not, I think I've had probably like 2 patients who've needed thoracic procedures in almost 10 years of practice. So learning the thoracic procedures isn't something that I think is really high yield. Sacroiliac joint injections, sacrococcygeal joint injections, and then of course large joint injections under fluoro. So knee, shoulder, hip are probably the big things that you can learn. Some fellowships may teach, spine fellowships may teach some other things, but anything kind of outside of this may be more of like a pain fellowship rather than a spine fellowship. So I'm an employed physician, and so this is kind of what some of the practice perks look like. And I debated for a while because we could do like a whole lecture series on like different practice types, especially for residents and fellows who are getting ready to look for your first job. There's quite a bit of difference between being an employed physician and then working for like a physician-owned group. There's pros and cons to both. I did look at both when I was applying. It ended up coming down to being an employed physician with a big hospital system where I'm at now, or being an independent contractor with an orthopedic group. When it came down to it, when I looked at the pros and cons, like for me personally, it worked better to be an employed physician, but it's everybody's situation is a little bit different. But being an employed physician, some of the things, and just being in spine in general, there's pretty much no weekends. There are some places now trying to be more competitive that have weekend hours because there is some demand for that, but usually they'll rotate that through people so that, if you do have to work a weekend, it's like maybe one weekend a month, and then they give you for whatever days you work on the weekend, you get those 2 days back during the week, so you're still only working a total of 5 days. But my clinic's only open Monday through Friday. The outpatient clinics, we are not open on holidays. I don't have any call at my practice. That's different, that varies, but a lot of times, like especially with spine, there's really not a lot of call. If you set up your practice really well, if you have staff that do a really good job with educating your patients, we really don't have a lot of call. The ER covers for us. It's very rare that our patients go to the ER. We always get notified when they do. And I think in 10 years, we've had maybe like less than 10 patients go to the ER. I've gotten less than 10 notifications that people even tried to call somebody after hours. So if you set up your practice right, there shouldn't be a lot of calls. But that's not to say that certain practices don't have call for spine. I really like being an employed physician. You have a lot of support staff typically. So you have a nurse, CMA, we work with rad techs, we've got a front desk team and an intake team that's handling phone calls and new referrals. And we have a manager that kind of oversees the staff. So those are some of the practice perks. And some of these are specific to being an employed physician. So just from my side, again, being an employed physician as opposed to being like an independent contractor with an orthopedic group, we've got a decent amount of job security. Being an employed physician in a big system like this, they typically tend to pay you fairly. That was the one thing I didn't like with that other orthopedic group is that I couldn't negotiate with them. What they thought would be fair for a PM&R doctor, I did not consider to be fair at all. So being an employed physician, they look at like national numbers. We have fair pay. We have really competitive benefits, and the benefits, it's not just the insurance piece. It's looking at vacation time and who covers you on vacation. That's another thing, if you're an independent contractor, when you go on vacation, you still have to pay your overhead costs. So even though you're gone, you still have to pay your support staff. You still have to pay for rent. You still got to pay for the utilities on the building that you're working out of. I don't have to worry about any of that as an employed physician. So a lot of just kind of extra things that come with being an employee of a big health system. You have a built-in referral base. You have a marketing team that works with you. You have people that are doing your billing coding, helping you with the prior authorization, helping you with the insurance contracts or if there's insurance issues. You have administrative support, which is a double-edged sword. You also answer to administration. But I think you want to look at that when you're hiring for a group is how well do people work with administration? How do they like administration? Sometimes it's tough. I would say one of the big downfalls is that sometimes you can lack control over your schedule. If the system decides, hey, everybody has to give at least 90 days notice before you can take vacation, you have to follow the rules of this big box organization sometimes. But overall, I really enjoy being an employed physician. So this, when I was a student, I was always like, why don't people tell us like how much people make? Like, how are we supposed to know anything if nobody will talk about this stuff? And so maybe I'll get in trouble for sharing this, but this is kind of the average amount. We have a range, and especially I kind of am down on the lower side, but again, I only work 0.8. So I'm going to make 80% of what a full-time physician would make. But this is kind of the average for what we're making as an employed physician. Now, if you independent contract, you can make more than this. I would say probably independent contractors can make between 500 to 700,000 a year, depending on where they work and depending how things are set up. Again, I wouldn't say that you necessarily get to take that home because you may have overhead costs that you have to pay out after you look at your take-home pay. But the compensation has come down. I remember like when I was in training, there were spine doctors that were easily making over like $1 million, and the reimbursement has really been cut for procedures. So, but this certainly, you certainly make a very, very comfortable living in this subspecialty. Being an employed physician, though, you can't write anything off. I didn't realize this. When you're an employed physician, your expenses are already covered by your employer. So the government looks at, well, there's not a lot of things that you would need to write off. So you can write things off, but it has to be like a certain amount of percentage of like your salary, which is like astronomical. Like I would never come close to purchasing that kind of those kind of things to be able to write things off. So you also end up, because you're a W-2 employee, the government sees every single penny that you make, and you end up getting taxed at a pretty high rate. But even so, the compensation, is pretty good. I just wanted to touch about board certification. So with PM&R, now that we only have the single accreditation for the graduate medical education, so your residency programs, there used to be AOA certified residencies and then the ACGME certified residencies. Now everything is ACGME. But before, if you were in an AOA residency, you had to sit for the AOA boards. And if you were ACGME residency, if you were a DO, you could sit for either. And I thought about just sitting for the AOA boards because that was what I really wanted to do as a DO, was be AOA board certified. But at that time, I was told by my program, hey, Jenny, if you don't sit for the ABMS boards, which is what the boards are for the ACGME residencies, it's going to look like you failed. So the program gets counted as having a failed person. Even though I didn't take it, it was going to look like a fail for my program. And I didn't want that because that's a black mark on the program. So ended up sitting for both. Now people who are going through, you will have a choice to decide whether you want to be AOA certified or ABMS certified. The AOA certification is totally equivalent to the ABMS certification. You cannot be discriminated against for having AOA certification. If the AOA hears about this, they will get involved immediately. I actually had this problem when I went to renew my contract. The contract said that they would only allow ABMS certification. And I said, well, you need to change this to allow for AOA certification as well. And they said, no, this is a standard contract, like it's ABMS certification. And I'm an AOA member, and I called the AOA and I let them know. And I didn't hear from the AOA. I was a little surprised until I got a personal phone call from the senior vice president of my organization personally apologizing for not including AOA board certification, and that they would immediately change that in the contract. So I don't know what the AOA said to them, but it was strongly worded enough to immediately get that changed with a personal apology from the senior vice president of the organization. But the AOA certification is for DOs. It's written for DOs, for clinically practicing DOs. So I would highly encourage you to pick the AOA certification. I'm still carrying both. The ABMS certification, it's really expensive. It's really arduous. The AOA certification is much simpler. So as a DO, I would strongly encourage you to be AOA board certified. We had some questions about accredited and non-accredited fellowships. So this is a really great question. So for the students, when we look at fellowships, so there's accredited, meaning that they're essentially like sponsored or given accreditation by the ACGME. And then there's other fellowships where they don't get that accreditation from the ACGME. And that difference means that whether or not you can sit for subspecialty board certification. Spine medicine is so subspecialized that currently ABMS does not have a subspecialty certification for it. They do have a certification for pain. So pretty much all of the pain fellowships are accredited. And then if you do a pain fellowship, then you are eligible to sit for the pain boards. Most of the spine fellowships, again, because it's so subspecialized, there's no accreditation, there's no board certification that you can sit for. So that's the difference between the two. The pain fellowships have more broad training. So, you're going to learn not only about spine, but, post-op pain management, headaches, abdominal pain, just kind of fibromyalgia, general pain. And then for spine, you're pretty much just doing spine, and then you have some musculoskeletal thrown in there because, people are going to have neck pain and shoulder pain, or it's, neck pain radiating to the shoulder. And then you actually determine, oh, it's actually shoulder pain that's causing neck pain because you're compensating because you can't actually move your shoulder the way that you need to. So with the spine fellowship, you actually end up with higher procedure numbers most of the time than your pain colleagues do. So at the University of Michigan, where I did my fellowship, I was in the fluoro suite, 2 or 3 days a week, every week, for that year. The pain fellows got to have 2 months of a spine rotation. So, that's like, they maybe got to do, 16 I'm sorry, like 32 days of spine injections, whereas I was doing spine injections year round. So when you came to the numbers, most fellowships require you to come out with 200 procedures. So the pain fellows were getting their 200, maybe 250, and I was like at 750, 800. So I had way more numbers than the pain fellows because that was all I was doing was spine. My experience coming from a non-accredited fellowship is that, at the time, especially when you were a resident and you were looking at it, well, should I do a pain fellowship because I can get board certified? How much do I need that board certification to get hired? How, will people, even if I do get hired with a non-accredited fellowship, our insurance company is going to say, no, we're not going to pay you because you're not board certified. This has been going on. People have been worrying about this, even 10 years ago when I was still in training. What I have found is it really, and this could be regional too, so I need to be a little bit careful with this, but in the Midwest, like in Minnesota, the Dakotas, Wisconsin, Iowa, and probably like the broader Midwest from there too, it does not matter. It does not have a bearing on getting hired. It does not have a bearing on pay. I would say that if you do a spine fellowship versus a pain fellowship, like it may lend yourself better to certain jobs. If they're looking for a spine specialist, like I think you'd be more competitive as a spine fellow rather than being a pain fellow. But the pain fellows, they still do a good job with spine. I'm not trying to say that, they don't. But if there's jobs too where it's like chronic pain, and spine is a big part of chronic pain too, but I always like to say, well, I'm not pain trained. I'm a spine doctor. So I liked that. There's a big difference between acute spine, which is what I mainly do, versus chronic pain. And so I actually liked kind of saying I'm not a pain doctor. I'm a spine doctor. So things can always change. It may be different in different areas of the country, but from what I found is that most employers, they just want to see that you're fellowship trained. They don't necessarily care whether it's accredited or not, and they want to see the competency, which is a number of procedures that you performed. So what to look for in a fellowship, you want to see if it's accredited versus non-accredited. And then, if you really want accredited, you want to apply to those. And if you're okay with non-accredited, then that's great too. I would say that, if it's a non-accredited fellowship, you do probably want it to be at an academic center, which I think most are. NASS has just come out with an accredited spine fellowship. That's pretty new, I believe, in the last year. I don't really know enough about it to see if that's going to be a big game changer or not. I think it can't hurt. Like when it's accredited like that, it means that they have like a formal curriculum, things that are definitely covered and taught in that fellowship, that they have faculty standard requirements. So I don't think it's a bad thing to go to a NASS accredited program. I'm not sure how much weight that will carry or if it matters, because like I said, most employers haven't really asked about, I was never asked, is your fellowship accredited or not accredited? They just saw like, oh, you're fellowship trained. Great. How many procedures have you done? Fantastic. I would say, you want to ask how your fellowship is set up. Is it rotation based where you're, doing, like you have a month of, EMGs, or you have a month of clinic, or you have a month where you're going with rheumatology, or is it the same schedule year round? My fellowship was the same schedule year round, so meaning I didn't have rotation. So it meant every Monday I had clinic, every Tuesday I was working in the EMG clinic in the morning and then doing procedures in the afternoon. So you want to ask how it's set up. You want to ask who you're working with. Do you have like one person that you're working with? How frequently do you get to see your fellowship director? What other staff are you working with who are training you? How are you supported? Some fellowships like mine, you're essentially treated as an attending. So I had like a secretary who would support me and help like contact patients and send out letters and things like that. But if you're expected to be an attending and you don't have support staff, I guess you would want to know that when you're looking at a fellowship. Do you have your own patients? I had like my own, Mondays were my clinic. So any patient that I was seeing there, like those were my patients that I would see as a new patient and then be expected to see them in follow-up. How much procedure time do you get? And then when you're in procedures, are you one-on-one? Are there other fellows that are going to be in there with you? Are there students or residents who are also going to be wanting to get their hands on procedures too? So asking about those types of things. And then what are the options to kind of train in associated areas? So if you want to learn how to do ultrasound guided injections, Botox, if you want to get really good at EMGs, the EMGs can go really hand in hand with spine. So ask about, is there flexibility to kind of be able to train in some of these areas? Excuse me. So how to prepare for a fellowship or how to make yourself as competitive as possible? I would say you want to work hard during residency. I know that seems kind of cliche, but you want to show up early. You want to be prepared. You need to do the work. It seems so simple, but sometimes like doing what is right for the patient, it takes longer time, or sometimes you think, oh, maybe if I could just do this. But if you really think about it, like if you're cutting any sort of corner, if you're just trying to get out early, you need to think about, okay, what is the right thing for the patient? Okay, that's probably going to actually end up meaning I have to do A, B, wait for somebody to tell me more about B, and then do C and D, rather than just skipping from A right to D. Do what you need to do to take care of that patient. Don't cut any corners. Don't complain. Residency is hard, but it's hard for everybody. If there's things where you really feel like something needs to change, like work constructively to make that improvement, but don't be the one that's complaining. You want to communicate with staff and support the team that you work with. I think I've seen residents where, they're a really strong resident, they're really smart, they do well with the patient, and then I see them treat team members very poorly. And I just think like, oh, you're not the person that I thought you were. And that comes back because people talk. And if that comes back to like your attendings, that's not how you show yourself to your attending. Your attendings are also going to see how you show yourself to your support staff and your team. So make sure that you're working well with everybody that you work with. Help out your fellow residents. You really want to kind of develop your reputation for being a hard worker and a team player and an upbeat person. Residency is very different. In medical school, you have these rotations and people only see you for a month. In residency, your attendings are going to see you for 3 years. They're going to see you when you're challenged. They're going to see you when you're tired. They're going to see you at your best. They're going to see you at your worst. They're really going to know you pretty well. So you want them to have an overall really strong impression of you. You want to make it easy for them to write you these letters of recommendation because they're going to know you really well after 3 years. Those letter of recommendations for fellowship, people expect to see like very personalized letters when you're applying for those. I would also say, especially for spine, you need to keep up with your OMM skills. That is something that almost every fellowship, when they were interviewing, would ask me about that. And I would say, yeah, I love to do OMM. I'd love to teach you about OMM. That's something that will really make you stand out. So I know a lot of people feel uncomfortable. They're good at it in their first or their second year, and then they feel uncomfortable because they don't see it very much in their third or their fourth year. Do whatever you can to keep up your skills. You have to practice on friends and family. Because your attendings won't allow you to practice on patients, that's fine. Most attendings, even if they're MDs, if you ask them if you can do some gentle OMM and you kind of describe what they're going to do, I've never had an MD tell me that I couldn't do it. So, if that does happen where you have an MD that won't let you do it, that's fine. Maybe you can talk to them later and kind of explain more, or even ask to demonstrate on them. You're not going to hurt anybody with myofascial release or gentle muscle energy. So make sure that you keep up with your OMM. I think that really makes you stand out. You want to do research during residency. It doesn't necessarily have to be spine based, but if you can write up like a case report or something with somebody, usually like if you're at an academic institution, you're working with fellows, they usually have something that they would like to have somebody else write up for them that they can also put their name on. So it should be pretty easy at an academic institution to get some research in and then write up some case studies. So that's it. Okay, we're finishing right at 8. So that's my email. I also put it in the chat, but feel free to email me if you have any other questions. And then Tremaine, I think you had probably some questions that I didn't cover in my presentation.
Yeah, I'll start. There's a conversation going on in the chat. I'll go with because you just covered it, but one of the follow-up questions was, are there any issues in becoming credentialed or acquiring professional liability insurance to practice pain medicine, or I guess spine medicine, if you complete an unaccredited like spine fellowship?
I have not heard of that. I don't, as an employed physician, usually like the employer can obtain that pretty easily. So I did not experience that at all in my fellowship. Even when I was applying with the ortho group, usually it's group coverage. So no, I don't think that there's any issue with that. I don't know that they can, if you're fellowship trained too and you have the numbers, I'm not sure how much they could, because it comes down to competency. I don't even know that the insurance companies would look at like the accredited versus a non-accredited. I don't know that a lot of people outside of that necessarily know that much about it. But no, as far as like malpractice, I haven't heard of anybody having any difficulties with that. And I have never heard of any insurance carriers that have refused to pay because somebody wasn't board certified, didn't do an accredited fellowship.
Perfect, thank you. I'm going through the participant list, and I think we have mainly students and residents. So if you're attending, please just directly message me so I know that you're there and have a question, but I'll focus on the resident slash student questions, because one of the big ones that comes up is, once you are a PM&R resident, how do you know like what subspecialty is going to be a good fit for you?
That's a good question. I mean, I think if you truly, for me, I asked myself like, okay, I like doing a lot of things. Like I liked spinal cord injury, I liked brain injury, but like what I really just got excited about was spine. Like I loved doing OMM. I loved going into the procedure suite. So I think, if you ask yourself like, do I really feel happy? Do I really enjoy doing this? Do I, do I love this essentially? And not like, for me, it was kind of like, oh, I like doing spinal cord injury. I get to do spinal cord injury, but like with spine, I was like, I can't wait to do spine. So I think everyone's a little bit different in finding and how they determine what they like. Some people may just, kind of like it all. And then you can kind of look at, okay, well, I think I want to practice in this area of the country. Like, oh, there's more, jobs opening for, there's always going to be a lot of job openings for traumatic brain injury and spinal cord injury. So maybe you would just want to go with something that you like everything in general, but there's going to be a higher demand for spinal cord injury and brain injury. So you end up going into that. So I think it's hard to know exactly what your fit is, but I would say my advice would be like, really ask yourself, like, does this make me really happy? Could I see myself doing this like every day?
Perfect, thank you. Another one, I guess kind of for anybody, even attendings, is one question was, are there any particular advancements or new treatment methods that you're looking forward to in the near future? I guess specifically with spine.
Yeah. Oh my gosh, where do we start? Okay. So, I guess specifically in the spine, there was, about 10 years ago, there was this mild procedure that was coming out. Everybody was so excited about, even Mayo was buzzing about it. Mayo doesn't buzz about things, but Mayo was really looking at this mild procedure that was supposed to be this like very minimally invasive procedure that could treat patients who had lumbar stenosis, like tiny little incision, like the recovery time was very low, great for patients who, would be at significant risk going under anesthesia. Everybody was super excited about it. And then all of a sudden it just kind of fell off the radar. So I'm waiting for some of these minimally invasive things to maybe come back up and see if those will be helpful for patients that really aren't good candidates for surgery just because of their other medical issues. So there's endoscopic guided radiofrequency ablation procedures, which I'm interested in, but I haven't really seen like the benefit. I'm wondering if the technology is going to get better somehow where, we can do this without, right now, like you're doing it, but I haven't seen it done, but I was talking to one of my attendings. He's like, I watched it done. And he's like, you might as well just have surgery. Cause the cannulas that they were using were so big. So I think that would be interesting to see, because right now with the radiofrequency ablations, we're going off of anatomic landmarks and then electrical stimulation. you can't actually see the nerves. I don't think it's as big a deal the first time that you're doing a procedure, but the second time that you're doing a procedure, if those nerves don't grow back exactly where they used to be, you're still using those same anatomic landmarks to go after them. So if you could actually see them endoscopically, we might have higher success rates with that procedure, especially the second or third time around. I'm really hopeful that maybe one day we'll see hyaluronic acid injections into the spine. I know that they're doing that in Europe. It's not approved in the US right now. We're still waiting to get approval for the hip and the shoulder. I was told that we would get approval for that by the time I was graduating fellowship, and it's 10 years later, and we still only have it for the knee. So I think, and then the other thing, we've seen disc replacement in the cervical spine. There was disc replacement in the lumbar spine as far as surgery goes. I know I'm not a surgeon, but for some of these patients that you end up having to refer to surgery, it'll be interesting to see if they bring that back. They had it and then they took it off the market because it was failing at such a high rate. So it'll be interesting to see if they can come up with something that will be longer lasting in the lumbar spine. So.
Great, thank you.
Yeah.
For a fellow, here's a question. So newly matched fellow, any words of advice to maximize my 1 year of fellowship training?
Oh, yeah. I would say if you, just trying to get a feel for the setup like beforehand, seeing if I don't know if you're in close proximity to that fellowship, but going out and even meeting people or watching people ahead of time so you can kind of get a feel for things. If there's certain electives that you want to do or people that you want to work with, asking if that can be set up ahead of time. Sometimes that has to be arranged months in advance. Like I felt really fortunate. Like I got to have clinic with the spine neurosurgeons. So I learned a ton working with the neurosurgeons. So, if that's something that you really want to do, sitting side by side with them in clinic, that may need to be arranged in advance. If you really want to work with I wish that I could have worked with rheumatology. That's one thing I wish that I probably would have set that up. So asking if you could work with rheumatology or other specialists, if you want to do EMGs, making sure that you ask for that in advance or ultrasound guided injections, just doing as much as you can to kind of create the fellowship that you want as much as you can within the flexibility of that program. Oh, you're on mute, Tremaine.
Sorry. Okay, so next one. Did you do most of your cervical injection training on models prior to humans, or did you jump right into humans under supervision?
Oh yeah, so at Michigan, we did them all directly on patients, which I'm not sure how they're doing it now. I think that a lot of people maybe start out in the cadaver lab and then move to patients, but we did all of our training on real patients. There are some really cool models out there right now. Actually, one of the AOC PM&R secretary and treasurer, he actually developed this really cool organic spine model. You have to keep it in the refrigerator so it doesn't go bad, but it actually looks like a human body. And then you just see the body part. You can't actually see the bones, and then you put it under fluoro, and then you can practice your injections on that model. And I think that's pretty cool. There may be other groups that start using that more, because that's much cheaper than cadavers and much easier to store too.
Great, thank you. I think the rest I have are kind of more attending focused questions. So unless an attending is here and wants to ask them themselves, I think it's better to just open up. So if anybody here who's in attendance wants to unmute and ask a question, I think, are you still good for another 20 or so minutes, Dr. Kendall?
Oh yeah, absolutely.
Okay, so feel free to unmute yourself and you can ask Dr. Kendall anything.
And if you don't want to ask on this again, my email is I'll put it in the chat again here. And it was at the end of my presentation. I know Tremaine can send it to you as well, but I'll put it here in the chat if anybody would rather just email me their question or questions.
Okay, well, if no one has a question, I have a question.
Sure.
I was wondering, because your case presentations were great. I was wondering how much in spine specifically, how much of the diagnosing do you do yourself versus treating something that's already been diagnosed?
I would say that 90% of the time, like people aren't coming in with a specific diagnosis. Sometimes they'll come in with an MRI, and sometimes whoever is referring the patient will say, hey, I see that you've got a bulging disc, so go see the spine center. And I'll be like, oh, that's actually not what's causing your pain. So I would say, when you get referrals from surgeons, sometimes there's a little higher chance that you actually have a diagnosis that you're coming in with, but I never trust anybody else's diagnosis. I always have just, even if they come in with a diagnosis and I feel like it fits based on what I'm reading, like I always do my own history and physical exam. And again, I think that's what sets you out as PM&R and just as a good physician, is to do your own history and exam. And a lot of times you'll pick up things that other people haven't. And then you can start going down the correct path and get them feeling better faster.
And if no one else has any other questions, I have just one more, and if that's it, then we can end it. But of course, if anybody has a question that pop up, please just unmute and ask. I was wondering though, I know regenerative medicine is really big right now, especially in PM&R. Do you do any kind of PRP type treatments with what you do?
So I don't right now. We're just starting to get into that. There's other physicians in my health system who are doing that. So that the mHealth Fairview is actually made up of 3 organizations that just kind of came together in the last 3 years. So originally, the original group that I was with, Health East, they were against doing cash-based procedures, which is essentially what PRP is right now, because insurance is not covering it. They consider it experimental. So we weren't allowed to charge cash for it. Now that we've combined with the 3 groups, one of the groups had already been doing cash-based. So now we've kind of discovered, oh, we can do that now. So we're hoping to we just met with a biologics rep a couple weeks ago. And so we're hoping to get that up and running. But I think that there's a lot of promising research now coming out about PRP. So I think that's going to be something that we see pretty big in the future. Great. Well, thanks so much, everybody. I really appreciate you coming out tonight. And again, feel free to reach out to me anytime if you have questions or if there's anything that I can help you with.